So let's talk about it. So in the beginning, we need to know the meaning of few words here, which are in relation to the level of consciousness. Now see here, the first of them is lethargic patient. Okay, lethargic patient means they're difficult to maintain in the aroused state. They are very sleepy. They cannot remain aroused. They are developing sleepy condition. They are known as lethargic. Obtunded state means responsive to other stimulation than pain. So they are lethargic already, but when we shout them, hey, can you listen to me? They quickly respond. Stuporous means responsive only to pain. Okay, responsive only to pain. So we need to probably pinch them and then they respond. Comatose or coma is the most severe of all those conditions. This is defined as a state of unconsciousness from which the person cannot be aroused even with painful stimuli. How much you pinch the patient, how much you give trauma to the patient is not going to wake up in case of coma. The person is deeply unconscious. This is known as coma. Okay, now we all know the meaning of these terms. Now see here. Let's move on. Now, some other important points are also there and which are very interesting also. They are known as persistent vegetative state or locked-in syndrome. Now, what do you mean by this? See this. Persistent vegetative state is a state of severe unconsciousness in which the person is unaware of his or her surrounding and incapable of voluntary movement. With a persistent vegetative state, someone may progress to wakefulness but with no higher brain function. So this is typically developed if there is delay in resuscitation, but somehow you have revived the cardiovascular function or pulmonary function in the hospital. But by that time, the brain is already dead. Okay, there is no higher brain function, but the heart and lungs are still working. This is known as persistent vegetative state. Now, this type of patients, we really do not know what to do, isn't it? So we talk with the family member. This type of patients will be kept under mechanical ventilator, and they can survive for a longer time in mechanical ventilator, because their heart is working. They are getting, oxygen through the mechanical ventilator machine, but their higher mental function, their cerebral hemisphere is gone. It is no more working. So even if the patient, survive, then what is the function, isn't it? So we discuss with the patient party, and then after certain duration, we discontinue this patient from the, life support machine, and within a short period of time, these people expire. This is known as persistent vegetative state. Another is called locked-in syndrome. Okay, so see that the meaning of locked-in syndrome is the person is totally paralyzed except for the eye muscle, but remains. I'm sorry for a small disturbance, in the middle. Can you see me again? Yeah.
Yes, sir.
Okay. Yes. Fine. Now we are online again. So I'm talking about the locked-in syndrome. This is a rare type of neurological condition where the person is totally paralyzed except for the eye muscle movement only regarding the muscle group, but the person remains awake and alert and with a normal mind. The person can listen to things, remember that, but the person cannot respond. Okay, person can move the eye muscle only. All other muscles of the body, voluntary muscles and skeletal muscle I'm talking about, will be paralyzed. This is known as locked-in syndrome. It is not synonymous to coma. In this condition, patient is awake and alert. okay, but the rest of the body is paralyzed. Now, another term is called brain death. Okay. This is an irreversible cessation of all brain function, and brain death may result from any lasting or widespread injury to the brain. For example, there is prolonged delay in resuscitation. Okay, there is no blood flow to the brain as a result of cardiac arrest. There is severe injury to the brain. All these things can lead to brain death. And brain death is diagnosed by loss of brain stem function. We routinely examine for brain stem functions like corneal reflex, gag reflex, okay, a vestibular reflex, all these are absent. Now, medically induced coma means this is a temporary coma or deep state of unconsciousness which is used to protect the brain from swelling after an injury. This is just like giving rest to the brain, okay, giving rest to the brain. So it's a type of temporary coma which is induced with the help of medicine. So the patient receives a controlled dose of an anesthetic agent which causes lack of feeling or awareness. Okay, and during that time, patient is admitted in ICU, and the doctors and nurses there closely watch the person's vitals. And they maintain the vital sign. The patient will be treated like that for a considerable period of time. Okay, we do not try this outside the intensive care unit because this is a very serious type of patient. It is used for certain types of cerebral disorder where we need to give rest to the brain. One of the important example I can give is a coma because of cerebrovascular accident sometimes. Okay, to settle down that cerebral edema, to settle down the raise intracranial pressure, this type of therapy may be necessary. Let's move on. Now, what is the pathophysiology of coma or loss of consciousness? In other words, what is there or what are the factors which maintains our alertness? Okay, this is known as reticular activating system or RAS. And this reticular activating system is the group of neurons and nerves which are present very, very deep down into the brain stem. And they have got connection in the thalamus, and through the thalamus, they are supplying the whole cerebral cortex. They are activated by noise, exercise, light, and overall general arousal of the patient. Okay, and they maintain the alertness of the patient by activating the cerebral cortex. So remember, if something is there which will depress this reticular activating system or injure this reticular activating system, then the person will be unconscious, or the person will be lethargic, drowsy, obtunded, or unconscious. Now see here, the reticular activating system is composed of several neuronal circuits connecting the brainstem to the cerebral cortex. This pathway originates in the upper brainstem, reticular formation, and project through the thalamic nuclei to the cerebral cortex. Means they connect this brainstem with thalamus and to the cerebral cortex. They are the important structure which regulate our sleep-wake transition and maintaining attention. Okay, but they maintain the alertness. If there are certain, etiological factor which interfere with the functioning of the cerebral cortex or the functioning of the reticular endothelial system, reticular activating system, I should say, then it can result in, loss of consciousness. And there are a lot of causes which can damage the brain like that. Okay, so let's talk about what are the etiology or the causes of loss of consciousness. Now see here, these are the common causes. Okay? The common causes means they are more common than the other. So please mute yourself. These are drug overdose. Drug overdose. Those drug which have effect on our brain. Drug overdose, then hypoglycemia, very important cause. Okay, we have studied this many times. Hypoglycemia, because our brain depends on glucose level. Head injury, different types of head injury. Any serious type of head injury can result in coma by causing a lot of problem inside the brain. There may be collection of blood clot in different, parts, okay, or different spaces. Extradural hemorrhage may be there, subdural hemorrhage may be there, then subarachnoid hemorrhage may be there, okay, intraventricular hemorrhage may be there, and intraparenchymal hemorrhage may be there. All of them are associated with raised intracranial pressure, and that can lead to coma. Stroke. Now, which stroke is commonly associated with coma? Which type? Which type? Is it hemorrhagic stroke or ischemic stroke? Which one? Which has a more chance of causing coma? It is always hemorrhagic one. Hemorrhagic stroke is considered more serious than the ischemic one. Okay. Subarachnoid hemorrhage, it may be a part of the stroke or it may be different. Convulsion, prolonged convulsion, like generalized tonic-clonic seizure or grand mal seizure, is usually associated with loss of consciousness. And alcohol intoxication, okay, heavy alcohol consumption or some of the withdrawal effect from the alcohol can also be responsible. Now, these are slightly uncommon causes, okay, than which we have mentioned before, but it depends on which part of the world are you in and from which part of the world this patient belongs. Okay, so some of the infection or infective etiology which are highlighted there are very common in our part of the world. Okay, infectious diseases are quite common. So this common and uncommon, is not justifiable in every part of the world. Type 2 respiratory failure. What do you mean by this? Anybody? Anyone? What is type 2 respiratory failure and how it leads to coma or unconsciousness? Remember, probably this topic was not discussed before. Type 1 respiratory failure mainly comprises of hypoxia, whereas type 2 respiratory failure mainly comprises of hypercapnia or in excessive level of carbon dioxide. And when there is excessive level of carbon dioxide, there is already hypoxic component as well. So type 2 respiratory failure is commonly associated with coma. Cardiac failure, no doubt about it. Heart failure, there is decreased cerebral perfusion, which can lead to unconsciousness. Arrhythmia, again, the heart is not functioning well, which can lead to cardiogenic shock. Hypovolemic shock, or any other type of shock for that regard. Anaphylaxis or anaphylactic shock. Hepatic or renal failure, which can depress the brain. Hepatic encephalopathy and uremic encephalopathy. Hypothermia and hyperthermia both. Meningitis, encephalitis, cerebral malaria, okay, brain abscess. These are different things. All of these are infectious, diseases. Diabetic ketoacidosis, which can result in unconsciousness, and Wernicke's encephalopathy. Now, Wernicke's encephalopathy is seen in which condition?
Alcohol intoxication, vitamin B1 deficiency.
Exactly. It is associated with vitamin B1 deficiency, which is seen in chronic alcoholic people. Okay, that is known as Wernicke's encephalopathy. So all of these are associated with loss of consciousness or coma. So the causes can be so many. We need to take a very good history and do the physical examination with some investigation. Let's move on. Now, what are the signs and symptoms, or what are the clinical features of coma? Now, remember, coma is not a diagnosis. It's not a final diagnosis, okay? It is just one of the condition. So if you diagnose coma properly, your half diagnosis is done. Another half of the diagnosis is still remaining, and that you do by good history taking, examination, and investigation. So let's start with the diagnosis of coma first. The sign and symptom of a coma commonly include closed eye, depressed brainstem reflexes, such as pupils not responding to light. Pupils may be dilated. No response of limbs except for reflex type of movement. Okay, sometimes those movements are from the patient side themselves. It is not voluntary. No response to painful stimuli except for reflex movement. And Glasgow coma scale usually between 3 and 8. So you already know this point. Glasgow coma scale score less than 8 is called coma. And the lowest Glasgow coma score is 3. So between 3 and 8, usually these patients are comatose. And there is irregular breathing. The heart is functioning normally. Breathing is there, but it is a bit irregular. And apart from that, the brain functions are severely depressed. This is the state of coma. Now see here. So how to do initial resuscitation in a coma case? For example, a patient is brought with coma, don't start history taking, during that time. Make sure whether the patient is stable or not. Stability of the patient is the paramount importance. I always have time to take history later on. So this is such an important point. So what are those initial examination you do and resuscitation you do if it is necessary? Now, please pay attention here. This is very important knowledge. Airway and cervical spine is the first thing. Whatever the cause of coma, a patient may die or suffer brain damage due to airway obstruction, respiratory depression, or circulatory failure. So we have to make sure, okay, the airway is clear and patent, and the person should be able to protect the airway. If the person cannot protect the airway on his own, which is a real problem in case of coma, because the gag reflex is gone or depressed in coma. So if there is any vomitus, any food particle, anything in the oral cavity, it can be easily aspirated towards the airway. So better thing to do is putting an endotracheal tube inside the trachea with a cuff type of endotracheal tube. Okay, that is the best thing to do. Immobilize the cervical spine if trauma is suspected. And how to do that? How to immobilize the cervical spine? Yes, how can you do that?
It's applying the splint from both sides, wide splint,
Okay,
and then
good.
tightening.
Yes, that is one thing. Is right. Applying the splint from both sides so that the neck cannot be moved. Or other one is collar. Okay, this is known as cervical collar. There are two types of cervical collar. One is soft collar, another is hard collar. Now, hard collar is needed if we suspect fracture of the cervical vertebra, and relatively soft collar is fine if only soft tissue injuries are there. Okay, cervical collar is available easily these days. Second is breathing. If breathing appears inadequate, then ventilate with oxygen using a self-inflating bag with an oxygen reservoir. This is known as AMBU bag. Oxygen reservoir is there, and we connect that AMBU bag with the oxygen supply or the oxygen tube. Okay, then we give ventilation of the patient. An uninjured patient who seems to be breathing adequately can be examined supine, but nurse him or her in recovery position to decrease the risk of airway obstruction. We have studied this just now. Just put the patient in the recovery position. Okay, if there is not much injury to the patient, if cervical spine is already immobilized, then we can keep the patient like that. One advantage is there is no risk of aspiration, and another advantage is, the tongue cannot fall back and uh, uh, block the airway. Record the respiratory rate. Just one a quick examination or counting of the respiratory rate would be enough. Regarding the circulation, measure pulse and blood pressure in the patient. What is the pulse rate and what is the blood pressure? Observe and feel the skin for color, sweating, and temperature. Obtain reliable venous access, monitor ECG, and replace IV fluid if indicated. All of these are such an important point. So when you are in hospital or when you are in the emergency room, remember, you are the main doctor there, for example. So you are the one who will quickly check the pulse of the patient, quickly feel the skin. What is the color of the skin? Observe the color of the skin, whether the patient is in cyanosis or patient is in pallor or patient is in jaundice or something like that. Look for excessive sweating or not. Palpate the skin for fever, okay, and measure the temperature. How much is the fever? Sometimes patient is too cold, and hypothermia is responsible for that. Sometimes patient is having, high grade fever. Okay, hyperthermia may be responsible for that. Okay, make sure these are not present there. Then ask a very experienced nurse to get the venous access, that is IV cannula. Why I am saying nurses, because nurses are much more experienced in putting the IV cannula than the doctors. Okay, this is a reality. Okay, so don't try to do everything on your own. Ask help from other people who can do that quickly. That is such an important point. Monitor ECG. Make sure how is the cardiovascular function. Who knows? This coma is because of the heart condition. Okay, and replace IV fluid if the patient is in shock or if you suspect there is decreased perfusion. So this is known as resuscitation. Now look for the consciousness level or judge for the consciousness level in the patient using Glasgow coma scaling. We'll talk about that a bit later. Check the blood glucose and treat hypoglycemia immediately. Okay, check for the blood glucose level. And if blood glucose level is less, you treat for hypoglycemia quickly. You don't need to wait. Now, how to check blood glucose level on the bedside? Is there any way? Yes. Is there any way or not?
Yes, sir. There is some glucose strip available.
Good. These are called glucometer. It's absolutely right. These are called glucometer. This glucometer can quickly give you the reading, if one drop of blood is mixed with those, then it can give you the reading. These are called glucometer. And glucose strips are inserted in one side of the glucometer, and it will give you reading there. Okay, it is a not exact or accurate, but it may help in that situation. If there is severe type of hypoglycemia, you got the diagnosis. This is the cause of a coma. Okay, you can start the treatment, and meanwhile, of course, you can send the blood for the confirmation in the lab. Record pupil size. Okay, pupil size should be recorded, whether they are widely dilated or are they of the same size. For example, pupil is widely dilated on one side, but it is normally reacting on one side and the patient is in coma. What does that indicate? Pupil is only dilated on one side, What does that indicate? Any idea? Anybody? That means there may be some focal lesion in the brain, some focal lesion, maybe some hemorrhage on that side. Okay, and the third cranial nerve on that side may be compressed or damaged. So these are the different clues which is provided by you, by the patient to you. So if bilateral pupils are fixed and dilated, okay, this is already severe type of damage done. And this is a picture of, uh, raised intracranial pressure, okay, massive amount of, brain injury, which results in both third nerve damaged. So all these points are important here. Give slow IV thiamine to patient with a history of alcoholism or who appear malnourished, because who knows, this is a case of Wernicke's encephalopathy which is causing the problem there, and thiamine is the treatment in this type of situation. Now let's talk about some other thing, how to confirm the diagnosis. These are the resuscitation thing we have been talking till now. Let's move further. Perform a general examination and medical history check. Now you have stabilized the patient, isn't it? Now you have time to do these things. Okay, so a detailed general examination and quick medical history checking should be done. Who knows, this patient is a diabetic patient. So can you tell me what are the causes of unconsciousness in a diabetic patient?
DK, sir.
One is decay. Any other?
Hypoglycemia because of drugs.
Very good. Hypoglycemia, excellent. Any other? Any other thing you can correlate? Maybe relation, not exactly by diabetic, but because it will lead to some other thing probably. Yes.
So diabetic people are usually having hypertensive. They are usually hypertensive, so maybe hypertensive condition, the stroke occurs
Yes.
in brain, and that is causing coma.
Exactly. That what I mean. That's what I'm giving clue. Think some other. It may not be directly caused by diabetes, but diabetes is responsible there. Like, very good answer. First, diabetic ketoacidosis definitely leads to coma. Then hypoglycemia, it is commonly seen in diabetic people, especially drug related one, or if they skip their meal, or if they indulge themselves in a heavy exercise, that may be responsible. Okay. And third one, diabetes is an important risk factor for atherosclerosis. Atherosclerosis results in ischemic type of stroke, and ischemic type of stroke, if it is a massive one, it will lead to coma. Okay, so see that. So these are a bit of association, and I'm just stimulating you to think in that direction. So quick medical history check is important. This patient may be hypertensive. Now you can give a lot of reason for that. Similarly, make sure the patient is in an actual comatose state and is not in locked in state or psychogenic unresponsiveness. Now this is a challenge for us. Sometimes patient is in psychogenic unresponsiveness. There is no real organic disorder inside, and this is a type of psychiatric disorder. We can call it conversion disorder. Okay, so how to diagnose this condition? Now see here, we do cold caloric oculovestibular reflex test. So irrigate an ear, okay, with 60 to 100 ml of ice cold water. A patient in a true coma, means not caused by psychiatric condition, with an intact brainstem, shows a slow tonic deviation of the eye, means the eye, which is towards that ear which you have irrigated, followed by rapid correction to midline. So there is a slow tonic deviation of the eye towards the eyes or towards that ear, followed by rapid correction to midline. Whereas patients with damage to the brainstem show no response, because this type of reflexes are controlled by brainstem. So if brainstem is already dead, remember, there is no response. This patient is usually dead already. A patient who is awake shows fast phase nystagmus away from the cold air. And this is a case of psychogenic unresponsiveness. Patient is awake inside. Okay, there's no real damage done to the brain. And in this situation, if we do cold caloric test, patient will show fast phase nystagmus away from the cold air. This is a very important clinical test. Resistance to eye opening is another important feature. A person with coma doesn't resist, cannot resist actually. Okay, he can easily open the eye and see the pupil. But a person who is in conversion disorder will resist the opening of the eye. This is another important clue. Now, some other important points regarding the diagnosis of coma are Glasgow coma scale. How severe is the coma? Okay, Glasgow coma scale should be assessed and find the site of the brain that may be causing coma. Now, this may be done by different type of examination and investigation. Take blood work to see if drugs were involved or not. Okay, tell me some of the drugs which are, you know, depression to the central nervous system, which can depress the central nervous system and can result in coma. Anyone?
Sir, benzodiazepine, antiepileptic,
Very good. Benzodiazepine. Yes, good. Yes.
and
Even barbiturates. Yes, barbiturates like phenobarbital and opioid analgesic. Opioid like morphine, heroin, methadone, these type of drugs, and even
also,
tricyclic. Yes, yes,
also there's some substance like ammonia, sir. It's high in blood. May
exactly. You're right. Absolutely right. Okay, so I'll come to that. Uh, Tricyclic antidepressant are some of the drug. If the patient is taking overdose, it may depress the brain. Okay, then some other poisonous substance are there like organophosphate poisons. Okay, so many drugs, if they are in overdose, they may badly damage the brain, results in coma. Now, so that can be easily diagnosed by doing the drug level test in the blood. Check for levels of serum glucose, calcium, electrolytes like sodium and potassium, magnesium, phosphate, urea, and creatinine. Even the ammonia is right, just to make sure whether these are the causes of a coma or not. These are usually abnormal, different type of disorder. Serum glucose is abnormal in diabetes. Okay, calcium in hypercalcemic situation, which is associated with dehydration. Sodium and potassium, especially sodium, is associated with damage to the brain rather than potassium. But potassium may be decreased in certain other situations like some renal disorders. If the person is having chronic diarrhea, then potassium may be low, and that chronic diarrhea is associated with sodium abnormality or volume abnormality, which may be responsible in cerebral dysfunction. Okay, similarly you can give other reasons. Perform brain scan to observe any abnormal brain functioning using CT scan or MRI. Absolutely important test here. There are so many causes. So to rule out other differential diagnosis and to confirm the diagnosis, you have to go for CT or MRI. Continue to monitor brain waves and identify seizures of the patient using EEG. EEG is an important type of investigation, especially in case of epileptic patient. And grand mal seizure is one of the commonest cause of unconsciousness in an epilepsy patient. Sometimes even the complex type of partial seizure is associated with unconscious state. Okay, so these are some of the important diagnostic point. Now see there. Let's move further. Let's talk about what are the other important points in the history taking. Obtain a history from the ambulance crew and the patient's relative and the friends. Somebody must be accompanying that patient. Some family member or friends must have brought this patient to the hospital, or patient must be brought in the ambulance or something like that. So ask some important question to them. How was the patient found? Very important point. Okay, how was the patient found? If the patient was brought from his or her home, what the patient was doing during that time? Did the patient consume something? Did the patient fall onto the ground? Okay, so a lot of information is necessary. Was the patient having seizure? Something like that. When was he or she last seen? What is the duration? Is there any suggestion of trauma or not? Is there any history of fits or seizure or not? Has there been recent foreign travel or not? Many infections are quite common in the endemic areas. Previous symptom and medical history, like depression, should be asked. Who knows? Patient may have taken a large dose of antidepressant medicine and not any drugs available to the patient, so that there is a high chance of consumption of them. Maybe a suicidal purpose, or maybe depressed patient, a psychiatric illness, they may consume the medicine. So history taking is important here. Check the previous emergency department record and hospital note, which may really be helpful. Let's move on. Now, what are the examination you like to do in this patient? Examine thoroughly for illness and injury. Illness and injury. Check cloth and possessions for tablet and cards or bracelet warning of pre-existing disease. Now, this is important information. And if you remember, in some of the previous lectures, I clearly talked about this. In case of chronic type of disease like diabetes, like a bronchial asthma, even some other types of chronic diseases, patient may develop complication anytime when they are outside the home, and if they put some cards, or if they have some bracelet, something like that, and if they say, yes, I am the patient of this particular disorder, so can you please transfer me to the center, then any good type of human being can do that. Okay. uh, Humanity is still not dead, isn't it? People may transport this or transfer this type of patient to the center. Okay, they may have that much of time. This is a really important point. So we may know which type of disease the patient is having, and sometimes patient is carrying medicine in their pocket. Okay, just check for that. And sometimes in case of some poisoning, the cloth may be having some smell of the poison. A perfect example is organophosphate poisoning. There is a typical smell which is present on the cloth. Another is an increased respiratory rate, which may reflect obstructed airway, aspiration, pneumonia, diabetic ketoacidosis, liver or renal failure, salicylate poisoning, methanol poisoning, or ethylene glycol poisoning. All of them may result in increased respiratory rate. Okay, so these are some of the important points. Whereas respiratory depression, now decrease respiratory rate, may be due to poisoning like barbiturate, opioid, or tricyclic, which will depress the respiratory center, or because of increase or raise ICP. There may be irregular type of breathing and later on decreased breathing also. Brainstem compression or damage by stroke may cause rapid or irregular or intermittent breathing, which is known as chain Stokes respiration. Chain Stokes respiration is one of the component of raised ICP. Remember, raised ICP has got Cushing triad. What are the three things in Cushing triad? What are those?
Hypertension, bradycardia, and irregular breathing.
Exactly. Absolutely correct, both of them. So that irregular breathing is also known as chain Stokes respiration. This is just another term. Okay. So this may be asked in the MCQ exam. Please note that it is a part of raised ICP. Now, see there, if the patient is having bradycardia along with coma, so we consider hypoxia, complete heart block, raised ICP, digoxin, or beta blocker poisoning. All of them can result in bradycardia. Bradycardia will cause decreased cardiac output, and decreased cardiac output can lead to decreased brain perfusion, which is associated with unconsciousness. Hypoxia in the beginning may lead to tachycardia, but if hypoxia is very severe one, then bradycardia may also happen. If tachycardia along with coma, then we consider airway obstruction. Okay, see this hypoxia is written in tachycardia also. That's what I just explained to you. Hypovolemia, okay. Supraventricular tachycardia, SVT, ventricular tachycardia, VT or VTAC, or anticholinergic overdose like atropine overdose. Atropine is a common drug which is associated with tachycardia. So these are some of the important points. Now, see this, atrial fibrillation may be associated with cerebral emboli. Now, every student can give reason here. Atrial fibrillation is quite common in heart diseases like mitral stenosis or mitral regurgitation or even ischemic heart disease. So there may be dilated left atrium, and dilated left atrium may be associated with thromboembolic phenomena. On top of that, atrial fibrillation comes, that thrombus may detach and turn into emboli. It may go anywhere. It may be a cause of cerebral emboli here. And this cerebral emboli may be associated with coma. Now, hypotension along with coma. Hypotension along with coma suggests hypoxia again, shock, any type of shock, hypovolemic shock, anaphylactic shock, septic shock, neurogenic shock, or poisoning. Hypertension along with coma may be due to raised ICP, okay, or hypertension along with coma may be due to severe rise in blood pressure, which is associated with hemorrhagic type of stroke. That is also there. Measure rectal temperature with a low reading thermometer if the skin feels cold. Who knows? This coma may be caused by hypothermia. And coma is very common if temperature is less than 30 degrees centigrade. This is core body temperature. But for the definition of hypothermia, if the core body temperature is less than 35 degrees centigrade, then the diagnosis is confirmed. Now, during the examination, we clearly want to know what is the position or posture of this patient, also known as attitude of the patient. Now, see this. There are two important things which are shown in the picture. One is called decorticate type of rigidity. Another is known as decerebrate type of rigidity. Look at the clear difference here. The lower limbs look similar in both situations. Similar. Okay, there is plantar flexion in both condition. Okay, decortical rigidity is slightly internally rotated, but it almost looks same because they are acutely extended there. But the main problem is or difference is in the upper limb. In decortical rigidity, the upper limbs are flexed. Upper limbs are flexed here. Look at the elbow; it is flexed. Okay, and the limbs are adducted. Whereas in decerebrate rigidity, the elbow is extended and the wrist is flexed now. Okay. Here also wrist is flexed, but is extended with flexed, a bit pronated also. So these are the very important differences. And decerebrate rigidity is always considered more serious than decortical rigidity. Now let's talk about them. Decerebrate rigidity occurs when the site of lesion is between the superior and inferior colliculi of the midbrain, and a lesion below the red nucleus, okay, result in extensive extensor posture of all four extremity, that is rigidity of all four limbs. This is known as decerebrate rigidity or decerebrate posture, you can say. This is a very serious condition. All limbs are extended, okay, arms as well as legs, and they are rotated internally. Hallmark is elbows are extended. So this is how we separate it from decortical rigidity. Head may be arched to the back because of serious extension. It is due to increased general excitability of the motor neuron pool, especially gamma efferent discharge due to facilitatory effect of the uninhibited vestibulospinal tract. Now, because of this lesion, the control which is there on the vestibulospinal tract by the, cerebral cortex is gone. Okay, see this. So they become uninhibited. So this is the result of uninhibited vestibulospinal tract on the gamma motor neuron. So this is cerebral rigidity. Now, this is decortication or decorticated rigidity. This occurs when there is a removal of the cerebral cortex, okay, effect. When the removal of the cerebral cortex effect, the flexion can be explained by rubrospinal excitation of the flexor muscles in the upper extremity. So it is associated with rubrospinal excitation now. And the hyperextension of the lower extremity is due to the same changes that occur after midcollicular decerebration. So this occurs even higher type of lesion in the brain, decorticate posture. No, nobody is going to ask you about that in detail. Actually, they just want you to know how you separate these, and if the examiner asks, is this the decorticated posture or decerebrated posture? That's the important point. So the basic thing here is look at the upper limb. If upper limbs are flexed, especially the elbow, decorticate. If all are extended, decerebrate. Now, what are the other types of examination we like to do? We have to examine the skin. Look for pallor, cyanosis, jaundice, spider nevi, skin crease or scar pigmentation in case of Addison's disease, rashes in case of purpura fulminans or DIC, injection mark, okay, injection mark in case of infective endocarditis or any type of medical treatment. Who knows, the person may have taken the drug also, and signs of trauma. Now, what is the connection of jaundice and coma? Jaundice and coma.
Sir, liver
encephalopathy.
cirrhosis.
Hepatic encephalopathy, excellent. It's a connection with cirrhosis of the liver, or not always cirrhosis. Any severe type of liver disease or damage can result in coma. Yes, absolutely correct. Because of disorder, ammonia will release free because it cannot be converted into urea. At the same time, liver is damaged, so jaundice is a feature there. So this is the way you need to give explanation to most of these things. Okay, some connection is there. That's why we are examining this. Erythema or blistering over the pressure point indicate the patient has been unconscious for some hours. This is known as, a pressure change occurring there. Now, what are the other, examination? Importantly, the neurological examination we do in this type of patient include Glasgow Coma scale, strength of the limb, tone of the muscle, and reflexes. These are the parts of our, central nervous system exam. Look for the optic fundus, okay, or examine the fundi. Fundi means examination of the retina with the help of fundoscope or ophthalmoscope. Examine for eardrum, examine for neck stiffness, and palpation of the fontanelle should be done in case of small babies who are less than 18 months of age. So these are the other things we like to do. Now, one small question here. Why to examine eardrum? What information you get from the eardrum examination? And coma, we are doing this in a coma case, remember that? Yes?
Sir, hemotympanium in basal skull fractures.
Excellent, very good, wonderful. So hemotympanum means collection of the blood clot, beyond the tympanic membrane. Who knows, this is a case of trauma, nobody have seen that. Okay, patient has got the fracture of the basal area of the skull, and then This is the result. Excellent. Another reason, probably the eardrum is bulged or perforated, and there is a component of infection there. That infection may have spread inside the cranial cavity, which might have caused meningitis or brain abscess, and that may have resulted in coma. See that? That is also another reason you can give here. So in medicine, if you can explain, if you correlate the thing, if you associate the things, teacher can easily accept your answer, because it is a possibility. They cannot ignore or they cannot deny your answer if you answer like this. Now, some lateralizing sign, okay, lateralizing sign should be examining. Lateralizing sign means focal neurological deficit, like facial or limb weakness, may be caused by stroke, intracranial bleeding, or pre-existing problem like previous stroke or Bell's palsy. So we have to examine for that. Who knows? They may be associated with coma. Okay, Bell's palsy is a individual type of disease. It is usually not associated with a coma, but other types of facial paralysis, for example, only lower one half of the face is paralyzed. Now that has a very strong connection with stroke or coma. Okay, so examination of the facial nerve has to be done. Ocular nerve palsy or divergent squint with coma can indicate Wernicke's encephalopathy requiring IV thiamine or even by tricyclic antidepressant poisoning. Divergent squint, okay, means the two eye are not converging at the same object. This is the meaning. Means they are deviated away from each other. Now let's talk a bit about Glasgow Coma scale, but I'm sure about it. Many of the students are quite familiar to this, but probably they have not revised it, isn't it? So let's do that now. It is particularly used in traumatic coma. In case of medical type of coma, for example, hepatic encephalopathy or uremic encephalopathy or any other causes, medical causes of coma for that regard, we may use ABPU scale. ABPU scale. Let me write that here. ABPU. Okay. Now, ABPU scale tells us A stands for what in ABPU? A stands for
Alert.
Alert. Alert.
Very good. A stands for alert. The person is, quite alert, and the person is responding to your voice, to your command, okay, or everything. B stands for
By voice.
exactly
verbal by voices.
verbal or voice. Verbal or voice. Patient respond, to your voice. P is for
To pain.
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 Patient is responding only to the pain. Means the consciousness level is substantially decreased. Okay, it is going towards the coma now. And U means on,
Unconscious.
yes, on responsive or unconscious. On responsive or unconscious. So this is called as ABPU scale, very commonly used in clinical practice. These are very easier to do. Okay, but it has some connection with Glasgow Coma scale according to the particular score. Now, Glasgow Coma scale provides grading of the coma by using numerical scale. If you say Glasgow Coma scale is 13, okay, in this person, and the same person you say next day Glasgow Coma scale is just 8. Now the patient is deteriorating. Patient is not improving here. So, regular calculation or estimation of Glasgow Coma scale matters a lot. It may provide prognostic information to the patient. Of course, if it is very low or poor, then probably significant brain damage has been done already. Now, Glasgow Coma scale has 3, important variables or parameter. First is called eye opening. second is verbal command, and third is, motor response. You can say verbal response, eye opening, verbal response, and motor response. Now, eye opening has got 4 points. Spontaneous eye opening, 4. Eye opening to voice, 3. Eye opening to pain, 2. And no eye opening even by painful stimuli or whatever you do is 1. So the lowest score is 1. The highest score is 4 in case of eye opening. In the verbal response, the maximum score is 5. So well oriented with time, place, person, 5. Confused, 4. But patient is still answering, but patient is confused, Inappropriate word, 3. Incomprehensible word, just cooing, okay, just moaning. You cannot understand those, what patient is speaking or saying, 2. And no voice, production is 1. This is the verbal response. Now, in infants and children, okay, we count this, verbal response by a bit a different way. Again, the maximum, score is 5, but we do this a bit of differently here. Appropriate word is smiling, fixing the gaze in a particular area where you have shown, and following the lead is 5. Consolable crying is 4. Okay, consolable crying. Patient is crying, or a child is crying, or the baby is crying, but baby can be, consoled. Persistently irritable baby, 3. Restless and agitated baby, 2. And nothing, no response is 1. Now, I was talking about Glasgow scale and the motor response. So the total points are 6. If the patient obeys command, it is 6. If patient localizes pain, then it is 5. If patient withdraws from the stimuli, it is 4. If the patient flexion in response to the stimuli, 3. If there is overall extension of the body, this flexion and extension are compared with decorticate and decerebrate rigidity also. So decerebrate rigidity is considered always more serious than decorticate rigidity, and no response at all is 1. So what is the maximum score and what is the minimum score in Glasgow scale? What is that? Yes, what is the maximum score and what is the minimum one?
So minimum is 3 and maximum is 10. 14 is maximum.
14? Are you sure it's 14?
15 and the minimum is 3.
Exactly, 15 and 3. Just add that. 4 plus 5 plus 6. So 5 plus 4 is 9. 9 plus 6 is 15. So 15 is the maximum. And the lowest one is 1 in each of the heading. So it is 3. So 15 is the maximum. 3 is the minimum. So this is how we interpret it. Total score is 15. A score of 8 or more, the chance of recovery is good. A score of less than 8 is comatose patient. A score between 3 and 5 is fatal brain damage. And the lowest possible score is 3. This is about the interpretation of Glasgow Coma scale. In clinical practice, Glasgow Coma scale is routinely done in a traumatic case of coma. And it is done almost every day just to make sure whether the patient is improving or deteriorating from before. Now, apart from Glasgow Coma scale, what are the other neurological examinations we like to do? Look for subtle signs of seizure activity. Okay, subtle signs of seizure activity like twitching of the ocular muscles or eyelid, unusual limb movements, which may indicate non-convulsive status epilepticus. Non-convulsive means I cannot see the thrashing movement of the body. Patient is not showing the typical tonic and clonic type of convulsion, but inside the brain, constant type of electrical activity is going on. This is known as non-convulsive status epilepticus. It is equally damaging to the brain. Look at the fundi or do the fundoscopic examination. If you see, okay, subhyaloid hemorrhage means, between the between the vitreous humor, okay, and the retina. Between the vitreous humor and the retina, if there is hemorrhage going on, this is known as subhyaloid hemorrhage, okay, and it can result in retinal detachment and then even the blindness in the person. If the person revive, of course, okay, if the person come out of the coma, then because of this serious effect, the person may become blind. And it may be associated with subarachnoid hemorrhage or some serious injury it is showing there. Another important point is spontaneous central retinal venous pulsation are rare with increased intracranial pressure. Remember, increased intracranial pressure will lead to papilledema. And in that papilledema, there are different types of changes going on in the fundus. One, the margin of the optic disc is not very clear. It is blurred. Apart from them, the blood vessels which are there, like the branches of the arteries and vein, they are not prominently seen. And even the pulsations are rare. Okay, let's move on. Now, hypoglycemia can cause localized weakness or coma and mimic stroke. Definitely. Hypoglycemia is an important cause of coma, okay, and it can mimic stroke. Coma without lateralizing sign is usually due to poisoning, a post-ictal state, a brainstem stroke, or hepatic failure. Means coma is there, but there is no, focal neurological deficit. This is the meaning of lateralizing sign. There is no, paralytic limb or paralysis of any cranial, muscle or involvement of any cranial nerve, which is, innervating some muscle in the head and neck area. Nothing like that. And these are mainly caused by poisoning, overall depression of the brain, post-ictal state, means after grand mal seizure, the patient may become unconscious. That is called post-ictal state. Brainstem stroke, uh, you know, uh, sometimes bilateral type of stroke is seen. So we really cannot differentiate what is going on there. Otherwise, brainstem stroke is usually associated with, involvement of some cranial nerve. Okay, and why this term is mentioned here? Because the reticular activating system is present in the deeper area of the brainstem. When that is affected because of this lesion, overall depression of the central nervous system occurs. Extensor plantar reflexes are common in this condition, though. This is Babinski sign. Babinski sign is an important feature of upper motor neuron lesion. So even if there is no paralysis going on, but extensor plantar reflexes may be positive. Now, in severe poisoning, there will be muscle flaccidity with respiratory depression and decreased reflexes. That is seen in poisoning condition. Coma with small pupil and respiratory depression is a suggestive feature of opioid poisoning. This is called pinpoint pupil on the both side, and there is depression in the respiration. This is in opioid poisoning. In unexplained coma, give a therapeutic trial of naloxone. Okay, this is a therapeutic trial. Remember, sometimes you cannot really differentiate whether this is because of opioid or not, because patient is already in coma. There's no other suggestive history. Nobody has seen patient, taking that type of drug or something, that type of history. So you can give a therapeutic trial of naloxone, and it may really help in this type of situation. But if you are a good doctor, you can really examine the patient. Bilateral pinpoint pupil with a very less respiratory rate is a very important feature of opioid poisoning, and then we can confidently give naloxone here. Now, what investigation we like to do in a case of coma? See there, blood glucose. Always do that, because hypoglycemia is an important cause of coma, and it is very easily treatable also. Arterial blood gas, routinely done. Who knows? Hypoxia is responsible for this coma. Hypercapnia is responsible, or acidotic environment. A lot of information is there. CBC, okay, or complete blood count, rules out infection, okay, like meningitis, encephalitis, brain abscess, cerebral malaria, there is some problem there. Prothrombin time, okay, especially is prolonged in case of liver disease, like cirrhosis of the liver, which is leading to hepatic encephalopathy. Prothrombin time is prolonged. Urea and electrolytes are routinely done to rule out uremic type of encephalopathy. Uremic. And electrolytes are also important, regarding, for example, sodium imbalance. Both hyponatremia and hypernatremia are associated with brain damage. So that type of answer you can confidently give. Now, check paracetamol and salicylate level if poisoning is suspected. Overdose of both of these can result in coma. Paracetamol can damage the liver first, and by damaging the liver, okay, it can lead to coma, again by causing hepatic encephalopathy. Okay, salicylate level or poisoning can do that. It can lead to respiratory type acidosis and later on even metabolic acidosis. Drug screening for sedative and hypnotics is not needed, but in unexplained coma, keep blood for later analysis if necessary. If patient is taking overdose of that, that can be diagnosed by drug screening test from the blood. ECG, mesoarrhythmia, and that arrhythmia may lead to decreased cardiac output, decreased cerebral perfusion, and then coma. Or this arrhythmia may have caused embolization, and that embolization is associated with coma. Who knows, isn't it? So these are some of the important points. Chest X-ray may show pneumonia, aspiration, trauma, or tumor. This may be associated with the hypoxia, and then the picture of coma. And CT scan may be needed to diagnose subarachnoid hemorrhage, stroke, or any head injury. CT scan is very, very important test in this case. Now the final part is the management. Okay, let's talk about the general management of coma. It's a very important topic, and a lot of questions can be asked when you start working in the hospital as a junior doctor. How to manage a case of coma? Maintenance of airway is the first thing here, because patient cannot protect the airway in case of comatose state. Gag reflex is absent, and anything can be easily aspirated down into the airway. That is known as maintenance of airway. And proper oxygenation is checked whether it is there or not, and then check for the circulation as well. Prevention of aspiration is done by endotracheal intubation. That is the best way. Cuffed endotracheal tube is kept there. Correction of dyselectrolytemia. Sodium imbalance should be corrected. Calcium imbalance should be corrected. Fluid balance is done in case of SIADH, syndrome of inappropriate ADH secretion, and a lot of central nervous system disorder and pulmonary disorders are associated with SIADH, and this SIADH is associated with hyponatremia, and hyponatremia may be damaging the brain. So fluid is reduced to 2/3 of the maintenance in the treatment of SIADH. Means restriction of the fluid is done. Very easy type of management. Manage hyperthermia accordingly. Decrease the temperature in case of hyperthermia. Okay, warm up the body in case of hypothermia, and try to find out the cause. Treatment of RAS ICP is done if that is responsible for coma, and that is done by IV mannitol 20%, dexamethasone, okay, faster and rapid breathing with the help of mechanical ventilation, that is known as carbon dioxide washout. Okay, and a typical position, head is elevated in the midline, about 30-degree elevation, and sometimes even the cold therapy is used. Okay, the head is covered in the ice cold water or something like that. So all of these are done for the treatment of RAS ICP. Now, nursing care is absolutely important point here. Okay. The nurses who are taking care of this patient has to take care of bowel and bladder regularly, especially the urinary bladder. Now, catheterization has to be done. And there are different types of catheter these days. One is called self-retaining Foley's catheter. So once we put that inside, we don't need to worry much. It is a retaining catheter there, isn't it? But it has a high chance of infection. Another is called condom catheter. Okay, in case of male, we can put condom catheter. It can be easily removed, and there is less chance of infection there. So it depends what is the preferability of the doctor or nurses there. Care of the eyes has to be done. Okay, so some artificial ear drops has to be put inside the eye, and padding may be done. Care of the back to avoid bed sore. Okay, frequent massaging, frequent powder application, and frequent change in the position of the patient. These are absolutely important point. If bed sore develops in this type of people who are in coma, that shows very poor management from the hospital side. Okay, it gives a very, very bad impression to the overall team which is taking care of the patient. And this bed sore is very difficult to control as well. Acute onset of coma of uncertain origin with no evidence of meningitis treated as a cerebral malaria in the endemic area, like where the case of malaria are so common. Acute onset of coma, okay, with no evidence of meningitis. Think about cerebral malaria and try to confirm it, by doing cerebro, CSF examination and other tests of malaria, like malarial parasite smear. Specific treatment is done for hypoglycemia. You give glucose, IV glucose. Diabetic coma, okay, you give insulin there. Insulin. If it is a case of DKA, insulin is the treatment of diabetic ketoacidosis along with IV fluids. You already know that. But there are certain other causes of coma in case of diabetes also, like hypoglycemia. Confirm it first and then give glucose again. Okay, that will take care of coma in hypoglycemia. Inflammatory disease of the brain and meninges, like meningitis, encephalitis, those should be confirmed and then treated accordingly. And metabolic causes or organ failure, diagnose first, like hepatic encephalopathy or uremic encephalopathy, and diagnose and treated accordingly. So these are the specific treatment for coma. But the general type of treatments are similar in most of the cases.